So CAR-HLH it's a hyperinflammatory syndrome. So hemophagocytic lymphohistiocytosis is driven by pathological T cell activation and natural killer cell dysfunction, which usually manifests with hyperferritinemia, coagulopathy, hypertriglyceridemia, and hepatic transaminitis. It leads to multi-organ failure, and usually for hemophagocytic lymphohistiocytosis, the diagnosis is based on the HLH 2004 criteria. However, in the setting of CAR T cell therapy, this criteria is difficult to apply. So some of the features in this criteria, for example, presence of fever and cytopenias, they're already present in patients receiving CAR T cell therapy. So it's difficult to obviously use this criteria. So one of the important things, I suppose, is to develop a diagnostic criteria to determine the CAR-HLH. Usually the median time of onset is 14 days, and it has overlapping features with cytokine release syndrome, which is obviously one of the main immunological toxicity of CAR T cell therapy. So the diagnosis can become really, really challenging in these patients. So I've come across a couple of different criteria that are being used. They mainly rely on presence of peak serum ferritin above 10,000 nanogram per milliliters in the CRS phase, and then subsequent development of either organ toxicity or biochemical criteria. However, I've come across one publication by Shah and colleagues from the US, where they put a lot of weight on the ferritin rise, which is greater than 100 micrograms per liter per hour within a 24-hour period, along with hypofibronegenemia to define early onset of CAR-HLH. So it has a huge impact on, so CAR-HLH, it has a massive impact on patient outcome, because once patients develop florid hemophagocytic lymphohistiocytosis, I think it is very, very difficult to overcome that excessive cytokine activation phenomena. So I think it is important to detect this as early as possible and institute therapy. So although there are some similarities between CRS and HLH, there are some key differences, which I think are presence of hemophagocytosis on a bone marrow sample and presence of hypertriglyceridemia. And then there is delayed coagulopathy, which is very typical with CD22 based CAR T cell therapy. So I think if we use some of these features to determine the presence of hemophagocytic lymphohistiocytosis, there's potential to intervene early. So although the cytokine profile is similar in CRS and HLH, because of some differences, particularly the persistence of the cytokine markers, as well as some unique cytokine markers which are typical with HLH, there is a potential to use other medications for therapy.